good afternoon, everybody, and welcome to the July meeting of the Authority, the last one before the summer. We have apologies today from Graham James. As usual, the meeting is being recorded in the interest of transparency, and the recording will be on the HFEA website fairly soon. And we have external observers online, as we always do. Oh, excuse me, I've got a bit of a cough. So let's start with declarations of interest. Geeta first, please.
Thank you. I have recently been appointed as the Pro-Chancellor of the University of Portsmouth, and there's no conflict of interest.
Congratulations.
Thank you.
Tim.
Thank you. I'm Tim Child. I undertake consultancy work for a Middle Eastern-based company.
Steve.
Thank you, Steve Troop. I'm a clinical embryologist, and I provide independent consultancy advice to the fertility sector in the UK.
Anya.
Freelance work within the fertility sector.
And finally, Alex Kappis.
Thanks. Non-executive director of the Care Quality Commission.
And congratulations on your appointment too. That's excellent. So the next item on the agenda, as always, is looking at the previous minutes and matters arising. The minutes from the authority meeting in May. Everybody has had them. They've commented. I think there was one very small change on 5.33, where just a small change where we said, I'll just tell you because we didn't circulate this, a member congratulated the team for the minutes had said outstanding good performance across all KPIs, and it was changed to consistently very good performance because that was in fact what was said. So I imagine that's fairly straightforward, and there are no matters arising that are not being discussed elsewhere in the meeting. So I think we can move swiftly on. And is everybody happy that I approve the minutes? Yeah. Okay, that's great. So the next item, as always, is the Chair and Chief Executive's report. Peter and I had actually quite a busy time since the last meeting. I attended a meeting of SCAC, which I think Tim will talk about in a minute. We also, Peter and I also met our sponsor team at DHSC for our annual accountability meeting. I think it is worth saying that, and I'm delighted actually, that the relationship I think with our sponsor team is a very positive one. We find that they are very responsive, when we have questions for them. I hope we're responsive when they have questions for us. And I think they are, I think it's fair to say that they are, very pleased with the way we're working at the moment and the how the HFEA works generally, and it was a very positive meeting. We also met, which we do on a sort of quarterly basis, the Fertilis group, which represents a group of clinics. What usually happens is they give us an agenda of things that are sort of on their mind and they'd like to discuss, and we talk through them, and we discuss areas in the sector that we would like them to focus on. These are mainly private clinics, privately run clinics whose patients are in the main self-funded. And again, it's very positive way of engaging with part of the sector and making sure that we are, communicating effectively to them and also them to us. That was good. The other thing that we are in the middle of doing is we've shortlisted the for SCAC, we do have one more vacancy for somebody with AI and data experience, data management experience. We have shortlisted. We're in the middle of interviews, and we're hoping, hopefully, to make an appointment over the next couple of months or so. Peter, I think that's all from me.
Thank you, Julia. Julia's covered a lot of what's there, but I'm happy to take questions on anything. I think the only thing to add for the public part of the meeting is just the reference to the work. We're supporting the Regulatory Horizons Council as they do a piece of work on the regulation of in vitro derived gametes, IVGs. So this comes out of the work, the discussions you had earlier, if you remember, both at SCAC and then at the full authority, you looked at a range of scientific innovations, of which IVGs was one of them. They do, I mean, not only is it a question of whether or not they would be lawful or not, and we think they're lawful in research, in a research setting, but not in a treatment setting, is clearly there are real issues about how one thinks about regulating these and other bioscience innovations, and that's why the Regulatory Horizons Council is interested in all of this. We're very much looking forward to their work. For the record, the Regulatory Horizons Council is an official advisory body to government. It's related to the Regulatory Innovations Office. There's a lot of acronyms around this space, but sponsored by the Department for Science and Innovation. And, you know, I think there is some really important work going on there, thinking about how the UK can continue to maintain, you know, one of its leading positions in terms of a flexible regulatory regime that copes with new science. So they're still very much at early stage on this, but when I get a better sense of how the work is progressing and likely timescales, I'll update the authority. So I hope that's helpful, but happy to take any questions on that or anything else.
Questions? Okay, fine. We also had a full suite of committee meetings since the last meeting. So I'm going to ask the various chairs to give a short summary of their activity. So first, Statutory Approvals Committee, which is Lisa Splinter, please.
Thank you. Is that working? Yeah. Okay. So the committee continues to meet monthly. The agenda does seem to be getting longer. The meetings are taking longer, but we are still managing to turn around applications within the appropriate time, which is very good. We have had some slightly complicated and challenging issues to consider, and you'll see that on a couple of occasions decisions have been adjourned while we await further information, but the Secretariat has been very good at obtaining that additional information in a timely manner so that we can then continue our discussions and reach a decision. The minutes for the meeting of the 23rd of June are not yet approved, should be out next week. Thank you.
Thank you. AGC, Catherine.
Thank you, Julia. Audit and Governance met on the, oh gosh, I haven't even got the date. That's terrible, isn't it? Sorry, 17th. Thank you very much. Yeah, we endorsed the internal audit annual opinion of moderate, consistent with past years. And we agreed further refinement to the ways of working with internal audit with our new head of internal audit. We agreed a plan to close all outstanding recommendations relating to opening the register, financial reporting and business continuity well before the end of this year. And we agreed that DSPT recommendations would be closed by January 26, or else risk accepted on the condition that the essential requirements within them transfer through to the Cyber Assessment Framework Improvement Plan, which takes place now instead of DSPT, and which will start in the autumn and continue through to 26. We were all very pleased to endorse Alex as the nominated AGC lead to work with the executive on information governance and cybersecurity risk. We received the external audit annual statement and management letter. which gave us a clean bill of health. Discussion focused on particular challenges to revenues and impairment of PRISM and how to avoid challenges relating to both next year. And we concluded that we would recommend that Peter, as accounting officer, sign the ARA subject to any changes arising from closing stages of the audit. We approved a full revision, grassroots review of the strategic risk register, which is in the papers today for you. And we tabled a number of suggestions for the executive to consider, including a reference to the fact that the new version of the strategic risk register streamlines to a small number of manageable strategic risks. And we had question about whether there was a danger that we'd lost sight of some of the important strategic risks that we'd previously had high on the risk register in relation to legislative change and the potential for applications to OTR significantly increasing and exceeding our capacity. We had very encouraging updates on both PRISM and Phoenix, which is the epicenter replacement, as members will know. And we discussed a revised and very impressive new HR strategy, making a few additional suggestions. I'm very happy to take questions.
Any questions for Catherine in particular? Otherwise, we'll. Okay. Tim Skagg.
Thank you. So SCAC has been pretty busy since the last authority meeting. So we've appointed 2 new external advisors, Asif Munir and Sarah Martins de Silva, with experience in andrology, neurology, and reproductive medicine and andrology, respectively. So it really strengthened the committee from that perspective. We're currently, as Julia mentioned, we're currently interviewing for another external advisor with AI, machine learning, big data, etc. That's ongoing. Since the last authority meeting, we've also updated the HFEA website to include information on androgen supplementation as an add-on, and also the impact of stress on fertility treatment outcomes. At the June 9th SCAC meeting, just to very briefly run through what we discussed, the MHRA guidance on the use of Ozempic and other GLP-1 drugs that used for weight loss, the possible effects on fertility. We discussed the use of platelet-rich plasma, so PRP, for intrauterine or intra-ovarian treatment, supposedly to improve IVF outcomes. And we discussed whether that should be considered as an add-on. It is considered as an add-on, and we're taking that forward with an external literature review, and that will be discussed probably at the next meeting. We discussed 2 horizon scanning topics, health outcomes in ART patients, including gestational surrogates and egg donors, and the recommendation from SCAC was to update and review the patient-facing information on the website, and also discuss the impact of the microbiome on fertility and treatment outcomes. And we were concerned by the lack of evidence, but also using with the current definition, microbiome testing and also sperm DNA fragmentation testing is not considered an add-on. So we had a discussion about whether it should be considered an add-on, and that's an item which I think we'll come on to. And there was a view from SCAC that we would ask the authority to consider changing the wording so it is then considered to be an add-on. And then the final thing before perhaps coming back to that is at ESHRA last week, we had the HFEA's annual Horizon Scanning meeting. And that topics included future use of mitochondrial donation beyond inherited disease, male fertility preservation, the role of in vitro spermatogenesis, and remote control IVF, the potential of robotics and automation within ART. So thank you.
Tim, just on Peter, this do we need to put to the authority your additional wording treatment?
Yes. Do you want me to cover that?
I mean, or I can, whichever you go. Why don't you do it? Yeah.
Okay. So in July 2022, the authority, I remember we discussed it and we agreed the definition of a treatment add-on, and it was very much about treatment and not tests. But increasingly what's happened is there's a slightly grey area where there are tests that are done pretty soon before treatment and then before IVF treatment, and then there may be treatments that start based on the test result that run into the actual IVF treatment cycle. So it's being blurred, and a lot of these tests are really being pushed quite heavily, particularly online. So currently, there's a lot of wording. The main wording at the moment is definition of the treatment add-ons are an optional, non-essential treatment that may be offered in addition to such proven fertility treatment. So we request that the two words "and tests" are added in. So it would be treatment add-ons are optional, non-essential treatments and tests that may be offered in addition to such proven fertility treatment. That would then allow us to add to the traffic light system, for example, microbiome and sperm DNA fragmentation testing, which are increasingly widely being used.
Everybody happy with that? Yeah. Okay, fine. Yeah, a lot of nodding. I think the answer is yes. Thank you. Go ahead. Good, great. And, okay, thanks, Tim. And Licence Committee, Graham James is absent, so Deputy Chair Alison McTavish, maybe.
Thanks, Julia. Graham gave an update at the last meeting about our May meeting. However, since then, we met on the 16th of June, and that was to consider the interim inspection report of the Homerton Fertility Centre that many of you will remember has been under considerable regulatory scrutiny in the last couple of years, and in fact had a 5-month period of suspension last year. However, this unannounced inspection on this occasion, the committee were very pleased to see that the PR of the centre is fully engaged with the HFEA Inspectorate, and indeed there were very positive and encouraging report, and we found no areas of practice that required improvement. So therefore the Licence Committee was able to continue the centre's licence. The minutes have been approved and have been sent to the centre, and they've been published. Next week we have another meeting, so who knows what that will bring. Thank you.
That's very encouraging, and well done for them. But also, our thanks very much to the Licence Committee, who've done an enormous amount of work on this, and actually really worked with the Homerton to help them improve and get to a point where hopefully things are on a good trajectory now. So thank you very much. So our next item, as always, we have a performance report where we look at the recent performance of the authority, and we measured through a range of KPIs. Peter leads on this, and members of the SMT take on various bits of it. Peter's also going to speak today on behalf of Rachel Cutting, who's at home recovering from surgery. She may be listening in, but we just want to say I'm delighted that it's all gone very well and look forward to seeing her back in full health very soon. So Peter, over to you.
Thanks, Julia. I'll obviously happy to take any questions on any of this, and what I'll do is I'll discuss the relevant issues as they come up in the report. So, I mean, the headline, I think, is that on the basis of the KPIs, performance remains consistently good. So 12 KPIs are rated green, 3 of them are neutral anyway. They're just volume measures, and there are 4 red. But I think the headline message from this is that the 4 red are all sort of, if you like, they have their particular reasons at this time, rather than represent structural issues or indeed long-term resourcing issues. So taking them in the order that they come, you'll know that the performance report begins with a number of KPIs relating to inspection, and clearly one of them. And what we do here is we measure both the outcome and the process. And it's the outcome measure that matters. That's the end-to-end licensing, because that's the one that, are we inspecting and licensing in such a way that we are making sure that all clinics are licensed, before their license expires. And that is green. Within the inspection process itself, we measure stages of process, which are useful for us, if you like, for management information. And we are presently not meeting our target in terms of inspection reports to PRs. So you'll know the process effectively is we go and inspect, the inspector writes a draft report, it's sent to the PR, we then get comments back from the PR, then a finalised report goes to a licence committee and the decisions is made. There are just, I think the fact we're missing currently on the inspection reports to PRs reflects some really quite complex issues. And our view throughout is the KPIs are, really important and useful, and we should be able to account to them. But when complexity is in the air, I'd rather we were slightly late and right than just meeting a KPI for the sake of it, because it'll only create problems later on. So my view strongly, and Rachel would be if she was here, is that the inspection team, is not facing kind of structural issues, which means you can't have confidence that inspection reports are not being delivered to quality and timing. But happy to take any questions on that. Our position on PGTM processing remains really good. We've been green for a very long time now, and Francis has already set out the enormous amount of work that SAC do in the decision-making bit, but in the processing bit, there's a lot of work there, but that's looking very strong too. I would also draw your attention, I think it's in page 32 of the pack, to the position on OTR. For the record, that's opening the register. We are making steady progress. I think we all hope we can make even quicker process. But if I think of the investment we've made in new IT and a modest increase in staff, it's starting to beginning to pay off. They are for the first time now being rated as green. In other words, crucially, we are now dealing with more applicants or getting more applications out the door than we're receiving. So the backlog is coming down. Clearly, we'd like that to come down faster still, because we're still conscious that some people are waiting too long. But I think the trajectory is really quite positive on OTR. And then lastly, moving on in terms of comments I want to make today to the sort of HR element, you'll see that both staff sickness and turnover showed a slight uptick. The staff sickness seems to me to be, entirely explainable by the usual sort of combination of seasonal sicknesses and we're now resolving a couple of long-term ill health issues, which in a small organisation have a disproportionate effect on the numbers. Turnover has picked up a little bit, but it's still very much in the bottom end of our range. You'll know we have a range of 5 to 15%, and we're now at just over 6%. I think that feels eminently manageable, and this is really just staff moving on as we would expect after a period of time. It's right and proper that they do so. And as long as that's manageable, we've talked about this before, I don't think that gives us any great concerns. Catherine, in her AGC report, reported on the HR strategy we took to audit and governance. I think that paints a picture of an organisation generally in very good health by most measurements. Funnily enough, next week on Monday, we've got one of our 6 monthly all staff days, which is a really useful check-in on the general sort of temperature of the organisation. And I'm delighted that Julia is joining us. And I expect that to be a really very positive day, despite clearly, as you know, some fairly, there is a lot going on and people have a lot on. But that's all I want to say at this stage. Very happy to take any questions on any of that.
Alex.
Thanks, Peter. I just thought it was interesting that PGTM received jumped to 16 in May, and as Francis says, the SAC meetings do seem to have more and more items. And we probably don't know the cause, but there's been a couple of high-profile media stories that I've seen championing the success of PGTM or following people on their journey to decide on PGTM, and I just wondered if it was just a data anomaly or whether we think demand is going to go up.
That's a good question. It does fluctuate. In fact, if you had like a couple of years worth of data, you'd find other high spots as well. We don't have an explanation for why. So for the sort of public record, PGTM is a demand-led licensing process. So, we don't go out there looking for serious conditions to potentially license. We let the market decide, if you like. So what happens is that families who come to clinics seeking to use PGTM, the clinic will discuss whether or not that particular inherited condition is on our list. And if it isn't, they will make an application to us. So, but you're right, Alex, 16 is a lot. We have long speculated that the greater public discussion, I think, about genetic inherited disease and genomics more generally may well over time generate demand, because, you know, you don't have to go back a long way before the vast majority of people who applied for a PGTM license, they found out there was a problem in the family because they had a sick child and they wanted to avoid another sick child. I think the open question is, does the just greater knowledge about genetic information more generally start to generate applications before people find out that way? The problem is, at the moment, I don't know the specific answer to your question, but I think it's the right thing to ask, and Francis may be able to comment on that.
So I think there's probably a couple of reasons why we're seeing more applications. If you go back 5 or 10 years, what was being licensed was predominantly the commoner conditions, multiple dystrophies, muscular dystrophies, Huntington, cystic fibrosis, and so on. But with the increased use of the new genomic technologies, things like whole genome sequencing, there is a greater proportion of children with complex multiple abnormalities who are now receiving a specific genetic diagnosis. They didn't have that 5 or 10 years ago, but that means that their parents can now request PGT with a view to avoiding a second affected pregnancy. And I think the other reason is increased take-up of routine carrier testing prior to conception is enabling some couples to discover that they both carry an alteration in the same recessive gene and therefore have a 1 in 4 chance of having an affected child. They haven't already had an affected child. There may be no prior affected children in the family, but they were the group that you were alluding to, Peter, of people now coming forward for PGT without first having an affected child. So they're both legitimate reasons for people to apply for a license for PGT.
Thank you very much, Peter. And just, I'd like to start by saying it's great to see the overall performance here, which I think is really good. And also, it's actually comforting to see a few reds there, because if everything was green, I would question whether or not we had the right KPIs. So again, that is important. And I think you provided reasonable explanations for why we've seen those. But I did just have a question on the inspection report, and it sort of mentions that the reason for this is the requirement of extensive QA. And I know also it's a relatively small number, so there's going to be a large impact of a small number. However, was there any learning from the fact that there had to be extensive QA on this that future informs our approach to this area? I did also have a question on the receipt, which I can, the debt collection within 40 days. I can ask that, or I can wait.
Can I park that one for Tom when he gets there? So on QAing, so just again for the public record, effectively, so an inspector or a team of inspectors might go to a clinic. They will draft a report, and before we sort of issue it back to the PR, we will usually do some sort of QA process amongst other inspectors. It's one of the checks we use to get a greater sense of consistency, because obviously there will be some very, very clear-cut instances of non-compliance, and others where you're making quite a sophisticated judgment about, you know, given the history of non-compliance in this clinic, does this warrant a slightly different response from a clinic that, say, had a very clean history of non-compliance? So that's what's going on there. And I think there are 2 reasons for a lot of Q&A. Either the issues are particularly complex, and or we've got relatively new inspectors. And there's a little bit of both in this metric at the moment. So we have had some new inspectors recently, and particularly they go through a sort of induction period before they become lead inspectors. And we have had some new stuff where we are consciously doing additional Q&Aing almost as part of our sort of induction. It's a very good tool for getting people all into the same sort of framework of mind, if you like, for considering inspections. There's also buried in there a couple of properly complex inspections. So I think it's a mix of both of them.
Peter, I just had one comment. Oh, Anya, sorry, you go first.
Thank you. You sure? Thank you very much. Just a quick question on the dip on social media usage and see if there were any thoughts about that. Specifically thinking of how reliable what we're putting out is on social media and wanting to keep public engagement with that.
I'm going to hand over to Claire soon when she goes through her, so maybe she can just, if we can store that question and pick it up then, if that's okay.
No, my question was just, I noticed we've had a higher number of OTRs recently, and there seems to be a bit of an upward trend. I'm imagining, I know when we discussed this some time ago, we thought that numbers would ramp up a bit, but is this sort of are they going up well how we think, or is it ramping up much quicker than we thought? Because obviously that puts some pressure on resource.
Broadly, it's following expected trends. All other things being equal, allowing for sort of monthly variations, we are expecting a steady increase in OTRs. Because effectively there are more people able to make one. It is a couple of years on yet before we expect to see on trends a really quite very significant increase. So our hope, Julia, is that the combination of the new IT systems and the staffing we've got will provide us with a manageable position for the foreseeable. But there is no doubt into the middle distance sort of thing, we are going to have to make some serious decisions about resources on OTR, because, working on the assumption that number of potential applicants is in some way related to number of applications for OTR, those numbers are only going in one direction.
Thanks. Claire, to you.
Do you want me to come in general, Julia, or particularly on Anya's question?
Come in on Anya's question and then.
So starting back with social media, I think it does fluctuate from one month to the next, depending what else is happening kind of in the UK and around the world. Sometimes we may hold things back and kind of not be as pushing things out as other times. But I think what says in the report is, we put out less that month. I expect that in June it will pick up again, not least because there's a 60-second video of Peter on social media explaining out for fertility trends. And if anyone goes on our website now, it kind of, plays on a loop as well. So I think it does fluctuate. And sometimes we making active decisions to put out less for various reasons. So that's on social media. In general, I think media interest continues to be high. We launched Fertility Trends in June since we last met in May. I think that had about 200 pieces of individual coverage. So, every national outlet that we could think of that covered it. And it led with our headline, which is about 1 child in every classroom is now an IVF baby. I think we had some interesting questions on the back of the media coverage that we'll have to think about. So some of the more challenging ones, I think was posed. Some of the more challenging questions journalists posed to me were about funding decreasing but increasing use of IVF, and have we done any analysis of socioeconomic status and IVF? And the answer is we haven't, and I'm not sure we could, but we do. If people remember, about 3 years ago, we looked at socio-economic brackets of donors. So I'm wondering whether there's something kind of we can look at in general, which I think would be interesting. And there was also questions about sort of stable or increasing use definitely over the last 10 years of IVF versus the global and national fertility decline, and what does this say? I know Geeta's spoken quite a lot about this in the media as well. So I think there's some interesting questions for us to think about. I guess kind of it does come back to the fact that our data is always very interesting. So I'm really pleased that the intelligence team and the comms team worked very, very hard on getting accurate and informative data out. So I'm really pleased with how well that's been received. We continue to get a high degree of media requests, which we respond to as quickly as possible on a variety of issues, including kind of licensing questions, questions about private sperm donors, of which there's been a couple of cases in the media, and also general interest in egg donation and surrogacy. And there was a very short debate in Westminster Hall, a sort of junior House of Commons, if you like, on egg donation in June, and it picked up on some of the topics discussed at SCAC that Tim mentioned about long-term health impacts of people having surrogacy and egg donations. So it's really helpful that SCAC have looked at that recently, and we'll be looking to see if, following SCAC's conclusions, we need to make any updates to our public information. We're starting to think about our next publication. Well, the first thing is we're going to discuss later on the agenda, which is a consultation on Choose a Fertility Clinic. But beyond that, our annual State of the Sector report in autumn, which looks at things from a compliance perspective, non-compliances, incidents, and the safety of the sector. We continue to do our day-to-day work of handling freedom of information requests, which are more complex than ever before. Parliamentary questions, and our licensing team continues to function very well. I think we've looked at some of the KPIs and noting the increase of applications for PGTM, which obviously kind of go through scientific inspectors and scientific part of compliance, and then comes the licensing team before going to SAC and being minuted. So there is a knock-on effect, and we're expecting that increase in applications to continue for a few months, going back to what Peter and Alex said, although we don't know that there's a specific cause for that. So I think that's all I wanted to mention. I know Tim mentioned the horizon scanning meeting at ESHRA. In September Authority, I believe we will have Dina and or Rebecca talking about the horizon scanning meeting and some of the presentations there with Tim's oversight, I imagine.
Thank you. Yeah, Zainab.
Sorry, I just wanted to draw attention to the KPI of the percentage of invoices paid, which was 31% in May. 3 high-value invoices were delayed for payment whilst awaiting approval. Excluding these 3 invoices, we paid 90% within 10 days. I think there might be an error with that one because the percentages don't mathematically add up. So it might be that 69% of invoices were paid rather than 31.
Can I just park that until it's Tom's? Absolutely. Let's just wait until, and then Tom, you've now got 2 questions to answer, but wait 1 second. Any questions for Claire? Geeta.
A comment and a question, Claire, just to say to the team, the press coverage was brilliant. When Fertility Trends was published, and on all platforms, including flagship BBC platforms, I thought it was excellent. And then the social media following that was also very good. So I think it really helps to raise awareness about the HFEA. People were talking about it, which is great. The only point about, and the quality of social media is quite good as well. About the website visits, where we have website users and website sessions, I wasn't sure exactly what it was. And are we actually tracking website visits and how long people are spending on different pages, just so that we have an idea about how much they're learning from the website? Thank you.
Yeah, that's a good question. And the answer is we are, and we're trying to kind of learn each time. So, for example, we know that people look at the kind of on a reports page, they look at the top and not necessarily scrolling down towards the bottom. So that's why we have more information at the top, the main points. We can track how much time people are spending on the website and what they're looking at. And each time we have a kind of big flagship publication like this, we have a sort of in-depth lessons learned. And one of those things is, you know, how many people did it bring to the website? Where did they come from? Did they come directly from social media or from other outlets? Did they watch Peter's video, you know, etc., etc. And we try each time to improve upon it. But if you would like to know a bit more about it, happy to, in either September or November, we could have a wider discussion about some of these things, possibly at an Authority Away Day or something like that.
I enjoyed Peter's video. But, no, I just wanted to come in on the report, and I agree with Geeta. I mean, in a very crowded environment. It was great. It was picked up in every news outlet, and I thought, as part of our new commitment in our strategy around information, I just thought the one in every classroom was such a brilliant way of simply crystallizing to people. And, you know, we could have said one in every 30 or whatever it was, but I just thought that was really great in a way of getting cut through, that it's just something everyone gets instantly and understands the proliferation of IVF. So yeah, I just thought that was really, really good.
Thank you. Just picking up on that point, I think the spikes in terms of proactive media mentions, to me, indicate the significance of our routine publications and the credibility that we've got, the authoritative voice that we've got, which in our new strategy, we've absolutely made a commitment to develop further. But it does seem to me that there's a potential for us to think even more strongly as the market develops and changes in the fast ways that we know it is, for us to act preemptively and to make very public statements about developments which we may take a view as an authority may not be in the public interest and or not consistent with the principles of the HFEA Act. So I'd like to think about taking that further as we meet as an authority in the next few months.
I think that's, you know, perhaps part of the bit of our strategy that's called using our voice. And I think it's definitely something we should consider. Claire, do you want to just?
Yeah.
I agree with it. And I would just add, just before we finish this section, that Claire, you know, the number of interviews you actually did on the day, I was sort of travelling at that stage, and I was trying to listen in at the various airports where I was to try and catch you, but you seem to be everywhere all the time, and it was great. So really well done, you and the team. Okay, so now over to Tom on the things you're covering, planning and governance and year end and so on, plus the two questions you've already been asked.
I was going to cover the KPIs anyway, but yes. So I think the issue with the debt collection is mainly a product of quite how busy it's been around the year end. As we've said before, we've kind of got some specific underlying age debt that we're collecting slowly and steadily, but I think this is just a product of year end. On the payment of invoices, yeah, we hadn't seen it go that low before, and I actually checked it this morning. The calculation's done on value rather than volume, and this is linked to our new contract with our new kind of the big IT project that's running at the moment. And because we were taking a little bit longer to kind of check through the first kind of invoices to make sure that we understood them and they were all correct, it took a little bit longer, and that's effectively it was 3 large invoices that, because it was value based, tipped us over the edge, but it is back up to 100% at the end of June. Moving back to planning and governance, we've now completed the business plan for 25-26, and we should be sharing the final version with the Department for publication, I think, by the end of this week. We've also finalised our current strategic risk register that's aligned with our new strategy that was reviewed by AGC in June and is up for discussion today. And Ali has also been working with the chair to refresh the board effectiveness review documents. Regarding the IT team, Phoenix programme is progressing really well. I'm really pleased. It's more or less within time and budget tolerance. We've still got really good engagement across the organisation. People are still engaging in kind of designing and testing the new system and the tools that it has. On security testing, we're waiting for the portal to be upgraded to the latest version before penetration can start in hopefully in mid-July. On business continuity, we're working closely still with a consultant. We had a session with SMT and kind of the crisis incident team on Monday, and we're having a full kind of exercise with at the staff away day next week. We've also been working really hard across IT and information governance to pull together all the evidence for the cyber assessment framework aligned DSPT process for this year. We made the submission on time by the 30th of June, and will include any kind of gaps or audit recommendations in the cyber improvement plan in the autumn, which Alex will hopefully be helping us with. Finally, on finance, it's been the busiest time of year. It feels like it's lasted forever, the audit process this year. The team have been hugely busy, in particular responding to the NAO's concerns around the accuracy of PRISM data for determining the income required, a lot of analysis and time from the finance and IT teams, for which we're really grateful. The process is very nearly complete. We're discussing the final internal approvals for publication of the accounts later in the meeting. The final bottom line on the accounts is a surplus of £475,000. This position is higher than expected due to a number of accounting adjustments made during the audit, including reversing the provision for refunds caused by PRISM. Regarding the 25-26 position, I think it's still a little bit too early in the year to have a clear picture of where we are. We're just starting to do a full quarter 1 review this week.
Additional questions for Tom?
Thank you. Sorry, Tom, just to take you back to the performance report. The point that I was going to make was that I noticed that over the last year, we've not actually hit the target. And I wondered, notwithstanding my point about sort of it good to see that we're checking the right things when we don't always hit it, maybe it's worth reassessing what that target should be given the general theme. But I do completely accept your point that end of year is different from the rest of the year, and that is a perfectly adequate explanation of why we saw that particular dip down, I think, further than it had gone before.
We have considered that, and I've talked through with the team. I think that they're confident that we'll be able to hit the target. And like I said, I think, over the last few months, we've been reducing kind of a collection of age debt, which we have mostly done, apart from one remaining particular organisation. I said it's kind of a slow, gradual process to bring it back. So it's going to take a little while, but hopefully it's going to keep going up.
Okay, so moving on, Tom, it's you again. So just to sort of make everybody aware, as you probably know, and public bodies are required to put their annual report accounts to lay them before Parliament, and we do this every year. But there is a very strict deadline, and our deadline is July 17th, so that's next Wednesday, I think. No, Thursday. And we're being asked to approve the annual report and accounts. Everybody's seen them. I know that there were a couple of typos, and I know I think somebody has, a couple of members have found again a couple of just tiny minor typos. So maybe don't bring them to this meeting, but immediately see Tom afterwards, because time is of the essence. So if they are just little things, just tell them afterwards. Otherwise, Tom, over to you.
I suppose I'll just start by saying previously we've been relying purely on AGC sign-off before laying the accounts, but on checking the standing orders, we realised that we also needed to have full authority clearance, which is why this is a little feels a little bit last minute. And I suppose that the main thing is that that AGC have been engaged in the audit and the annual report and accounts process for the last couple of months. They've gone through the meeting in June. We presented the accounts to AGC, and NAO were present, as were KPMG, who carried out the audit on behalf of the NAO. The audit report identified a small number of risks and issues, mostly relating to PRISM, both its accuracy for supporting HFEA income and its value as an asset, and provided us with some recommendations that we've accepted. Ultimately, the audit was completed without any qualifications, what hopefully Hopefully I haven't jinxed this by saying that, because we're still waiting for the Controller and Auditor General to sign, hopefully at the end of this week. But based on the reports and the discussion that AGC had with the auditors, AGC were content to recommend the accounts be signed, and the department has now requested to be published on the 17th rather than the 21st of July that's mentioned in the paper. This is quite tight, but we're confident that the report's pretty much ready to go now. A couple of minor additional proofreading amendments aside. Yes, as I said, we expect the CNAG to sign by the end of this week.
Subject to final amendments, which I think we'll delegate to Tom, as provided they're not sort of and the AGC actually to Catherine, provided they're not, you know, substantive, if you like. Are we happy that the report and accounts are published and approved? Any? Yeah. Lovely. Okay, lots of notes. And as I say, I know there's one or two just minor typos. Please give them to Tom as soon as you can. So our next item is strategic risk register. For particularly the newer members among us, we review our risk register twice a year. And basically now we've published published our new strategy. It's timely that we review the strategic risk register. Now it looks at current risks and with the degree of a tolerance level that we're prepared to take on those risks. And to make sure that we have picked up all the risks that we either have now or can foresee that arising out of the strategy. And I'm going to ask Shabir to take us through it. You've all seen it, but Shabir, why don't you highlight the main issues that you want us to look at, and then we can take it from there. Oh.
Thank you, Julia. I'll take it as the papers have been read. This strategic risk register was presented at AGC, as Catherine mentioned. SMT have looked at the previous strategic risk register and started on a blank slate for the new one. And several discussions we went through over the last few months to narrow it down to the key risks that we are looking at currently. So we've brought them down to 5 current ones, as these are the biggest ones that we're looking at currently. One of the purposes of doing this full review is to try and make it more timely, more relevant, but also to highlight the issues that we're dealing with now and update this as and when required as time goes on. So you'll notice from the papers that we've added one completely new information governance risk, taking into account the issues that we've discovered, but also highlighted from the Phoenix project, where we're moving our main data repository from CM, Content Manager, onto SharePoint. So all of those things have been encompassed within the strategic risk register as it's set up. So open to any comments.
Comments from anybody? I mean, firstly, can I say that I like the presentation. I think it's really easy to read. I think it's really clear. And as a working document, I think it will be, excellent. I'm assuming that this is the document that will sort of come to us in an updated fashion twice a year and so on, which is very helpful. Catherine, did you want to add anything just to that?
I think just to say that, for some time we've been talking at AGC about the strategic risk register being a much more overtly dynamic management tool. And it's really good to see how a zero-based review has come up with something which is very evidently a very active management tool. And I might opine that when we see it, and indeed when the authority sees it, there's actually going to be more shift, more turnover within those risks, more movement within those risks more quickly than we've ever seen before, which is an acid test of how effective as a management tool it's being. So we really welcomed it. Thank you.
I did have, it's just a question really on this cyber security risk, because I've noticed certainly over the last few months we've had a few sort of phishing expeditions, if you like, and our IT team have been really quick to pick up and crack down on anything that they think is at all dodgy, which is excellent. But when we're looking at managing cyber risk, is there something within civil service generally that's advising us, or do we get our own separate advice? How do we sort of sort that? Just for interest, Tom. Such a bit.
I mean, that's the majority of what the DSPT focuses on, is the processes and policies that we have in place for managing cyber risk. So we've got an IT security policy and a number of processes that kind of link to that. We are looking to get some external advice this year, just to kind of have a second look at how we manage those risks and what processes we have in place to kind of mitigate them. So and that's the process that we'll have with the implementation plan. The improvement plan in the interim.
Alex, yeah. Thanks, Tom.
I know at times we've been updated at AGC when advice from the National Cybersecurity Centre, or whatever it's called, has come down, and certainly I think again we've had very good oversight on AGC that we're attuned to kind of cross-government advice on various things, and I know authority members were shared the mitigations put in place following the hacks earlier this year to certain commercial companies, and which I won't say the mitigations in a private meeting, but I thought certainly we'd taken advice and responded very quickly and made some changes to the specific way those companies. So I think from AGC's point of view, we're taking the right advice from the right people.
Thank you. Anything else? Okay. Well, thank you, SMT and Peter. That's it sounds like a good performance report. I would just say that what with one thing and another, it's been a really, really busy couple of months. Everybody has been working absolutely at over full capacity, and I think I just wanted to minute the thanks of the authority to Peter and the SMT team, because I think the hours that have been worked over the last couple of months have really been over and above, but also the trains are all running on time as always as well, which is no mean feat, so it's really good. We're a little ahead of time, which is fine. I don't propose to take a break, because I know one or two people need to get off on or a bit before the end. So I think we can move straight on. But we do need Amanda and Kazuo. Are they on their way? Okay. So we'll just wait for them for a minute or two. So the
other way around.
I mean, we can do.
Yeah,
Kafka
can we
first,
do? Yeah, I'm happy to do Kafka. I'm happy to do Kafka first. I mean, the only thing they have to wait for a little bit, but I guess that'll be fine. Okay, so I'm going to. Sorry. Okay, all right. So I guess they'll probably be here in a couple of.
I think it's fine. So
okay, all right. Good. So, and I'm going to hand over to Claire for this. As everybody knows, we ran a limited consultation and agreed metrics for our interim Kafka, which is here they are. You know what? I think I'm just going to stop and regroup, because I don't really want Amanda and Kazuo to have to wait. So I think we'll go to you and then we'll come back. So Register Research Panel Annual Report. As I think most of you know, but for our newer members who maybe don't know, researchers obviously for a long time have had access to the data held on the HFEA register. We delegate decisions on who can use that data and how they can use it and so on to the RRP, the Register Research Panel, and then we ask them annually to report on their activities and tell us what they've been done. We sit, if you like, as an oversight committee for this item because we actually have delegated that authority. And I'm asking Amanda and Kazuo, welcome here, to take us through it.
You guys hear me? Yeah. Thank you very much for that introduction. To start us off, I will give a bit of an introduction to the wider work of the research and intelligence team over the last year. As you'll know, we have the longest running fertility register database in the world, which is a fantastic resource, and a key part of our strategy is making that data widely available to patients, clinicians, and importantly for this presentation, researchers. Can you go next slide? One of the ways in which you'll know that we do this is through our data publications. Just 2 weeks ago, we published our annual statistical release, Fertility Trends, which hopefully you'll have seen in the news. It received wide media coverage in making newspaper headlines, as well as being included in radio and TV broadcasts, mostly with the headline that around 1 in 32 of all UK births are now via IVF. In November, we published our family formations report, which is the second version of this report. And it was the first time that we published estimated numbers of reciprocal IVF, which was timely along with legislative change just a month prior. We also published our third version of our national patient survey, which allows us to get insights into patients' experience within clinics. And we received a record number of responses at about 1,500. We also presented our data publications in numerous places over the last year, including at ESHRA just last week, as well as Fertility 2025 and an international symposium in September. Next slide. Another way in which we make our data readily available is through the HFEA dashboard. This allows for a wide breadth of data to be available in a customizable and lay-friendly format. This was published in January 2024, and in summer of last year, we were the winners of the 2024 Trustworthiness, Quality and Value Award from the Office for Statistics Regulation in combination with the Royal Statistical Society and Civil Service World. The dashboard is updated annually alongside our Fertility Trends publication to include a new year of data. It's also updated to include new data along with other reports, such as reciprocal IVF estimations being included along with the family formations report. Since launch of the HFEA dashboard, we've had over 65,000 views of the page, and it's been an incredible resource for answering data inquiries that we regularly receive. We've also presented the dashboard in numerous places as well, including 3 presentations last year at the Royal Statistical Society, including one on the award. We've also been invited back to a panel discussion to discuss the accessibility of the dashboard as well this year. And we've also presented at a couple of government data related meetings as well. From there, I will hand it over to Kazuo, who will discuss data research.
Okay. Thank you very much, Amanda. So now going to talk about the Register Research Panel activity in the last 1 year. So since the last annual update in May 2024, RP met 6 occasions and fully approved 2 projects with 1 project conditionally approved listed here. The first project listed here is the first application from the researchers with the economics and demography background, and also the first project based in London School of Economics and Political Sciences. So they're going to use our funding body data, clinical commissioning group, CCG, and integrated care board, and they will project how the demand and the use of IVF would change if NHS funding criteria changes by looking at current differences in IVF use and NHS funding across the regions. And consequently, also, they would examine the impact of the potential or hypothetical and its funding changes on the birth rate in the UK. And the second project listed here is again the first application from, so they will be looking at association between the body mass index and IVF related outcomes. And this is the first project from the behavioral scientist with a dietitian background, and also again the first project based in the University of Oxford. So they will be utilizing our newly collected data, BMI, which we start collecting since the introduction of PRISM in 2021. And they will also see the association, whether the association may differ by ethnicity and the patient age group. And then lastly, this is a conditionally approved project. So research group in the University of Manchester will examine how the duration of in vitro culture affect the health and the pregnancy of human embryo. Next slide, please. So one of the key outputs from the RP is publications. There have been, in the past year, we have 2 publications from the RP approved project. Both are from the research group in the University College London. Their project examined the general health of IVF children, and then the paper on the top left corner look at the specifically perinatal health of the IVF children compared with the population control, and also the siblings of the IVF children. So they created a very unique data set and then examined the perinatal health of the IVF children compared to other children. And also, in the past year, there were 6 publications using our anonymized register, including the one paper collaboration with us, which highlights effectiveness and the safety of consecutive single embryo transfer compared to double embryo transfer. Next slide, please. So now moving to kind of the key updates to the authority members today. So which is the increased research engagement activities. We had a very busy 1 year to increase awareness and understanding of the register data in the research communities, especially in the UK. So last July, we launched the quarterly data research newsletter to improve communication with researchers. And most of the authority members probably have seen that this newsletter includes information on new HFEA publications, upcoming events, and the highlights of RFP project and their publications. So as of now, over 240 subscribers with a 60% open rates, which I think they demonstrated that their high interest in our newsletter. And also we'll be happy to hear any feedback and suggestion to the contents and how we can promote this newsletter further. Secondly, at the same time as the launch of the newsletter, we introduced a project inquiry form in our data research website, webpage, which was initiated by our research officer, Georgia May. And this is to streamline early contact with researchers. And the number of inquiries to us from the researcher increased past year, so reaching to the 18. So these also from the different group of researchers, including those working in the neurogenetics and epidemiologists interested in cancer survivors. So we really feel that we are reaching out to the wider range of researchers who are potentially interested in our data. Next slide, please. Yes. So the last but not least, I think the biggest activity in the research engagement last year was our first live webinar. This was open live webinar chaired by Claire, and we provided information on the HFEA register and how data can be accessed for their research, and the recording is also available on our website. So we advertised this event via research newsletter, social media, including the ASHRA website. And then more than I expected, so 180 people sign up with the webinar, and it's similar to any webinar, about half of the people sign up attended. So about 82 people attended. we have very engaging Q&A sessions, about 20 minutes. And then after the webinar, we received a very positive feedback from the attendees. And also the success of this webinar was demonstrated that the increasing number of monthly views of the data research webpage. So the next slide, please. This is the end. Just to summarize that the incoming years, we continue to increase the awareness and understanding of our data to support researchers to conduct quality research to contribute patient care, but also ensuring the confidentiality and the secure use of patient data. Thank you very much.
Thank you very much, Kazuya and Amanda. Firstly, any questions, comments from anybody? Gita.
Well, thank you. Comment and maybe a question. First of all, congratulations. I mean, it is such good information here, and I have to congratulate you on the dashboard because of its breadth of information as well as accessibility and simplicity, which I have been promoting widely because it's one easy way of telling people how to access information, and also the webinar finding out. Very good, and lots of publications which we should all be very proud of. You know what the database is facilitated. The questions are: do we get requests and applications from international research teams to our database, because it is the longest available database? Secondly, do we have access to some of the research proposals that have been approved? In particular, there's some to do with IVF demand based on NHS funding. I think it's from Oxford, and there's quite a few linkage studies going on at the moment.
So in terms of research, international researchers, so there are some interest from the researchers, but our registration say that we need to have a UK-based researchers. So mostly, so we haven't had any precedent yet, but they could collaborate if the chief investigator may be based in the UK.
Sorry, just to answer the second question as well for the research proposals. On our website, after projects have been approved, we have lay summaries of the project as well as understanding of how it's in the public interest as well.
Sorry, Claire, did you want to come in on that?
I was just going to say that each of the projects approved, if I remember, has got its own webpage with the abstract and a kind of further description, so we can send that round later so you can see the links.
Thank you very much. And just to sort of reiterate, I think it's wonderful to see this work. It sort of is great about transparency, but also the strategic aim of encouraging research so that can lead to improvement of what we're doing shouldn't be underestimated. So that you're so successful in doing that is really to be applauded. I have a kind of question stroke suggestion though, which is when I look at the engagement, which looks really excellent. There wasn't anything about trying to understand why people might not be using the data and what the gaps are. And I wondered what your approach was to maybe understanding that, and that possibly leads to questions around data linkage with other sets of data to be able to add things more broadly and what the approach would be in there. And I fully recognise that this is very sensitive data and therefore there are challenges in this space. But given that we're wanting to do this and make it accessible to try and achieve better services for people, there's also an imperative to at least explore what we could do. So the question was, are we doing anything in that place? And if not, the suggestion was maybe having some conversations with people who didn't take things up might be something to consider in your future engagement.
Thanks, that's really helpful. That is definitely something that we're looking at for the next year. This past year has been a lot about kind of making sure people are aware of us and the data that we hold. But the next year, I think we're going to concentrate a bit more on making sure that we have understanding for those who aren't applying to the RRP, what the reasons for, or those who would use anonymized register data. Are we missing fields that are of interest to them, and how we could kind of make that more widely accessible and easier for them to access as well in future.
Catherine?
Thank you. Just to echo that it's very gratifying to see that such really good lateral thinking about how to expand our reach has paid off. That's really great. Two questions. Firstly, do we feel that the progress that we've made so far is as much as we can do? In other words, you know, are there further formats and further initiatives which we have in the pipeline, or do we feel that we've done as much as we can? And secondly, but related to Tom's question, when we do engage in the ways that we have this year, do we ask proactively for suggestions about additional events, methods, media that we could use in order to stimulate even more applications?
Thank you very much. Further formats and initiatives in the pipeline, that is definitely something that we're thinking about right now, considering what other organizations are doing, what we could learn from them, considering how data security has changed over time, considering whether trusted research environments are something that could make access easier. So we'll be looking at kind of all of those things and just discussing it with researchers, seeing kind of what would be the best approach with that. For the second bit about engaging with people about the research activities, following the webinar, we had a feedback form where people were able to suggest future webinar topics, which was extremely helpful. A lot of them were interested in learning about projects that have used the RRP and data from the register in the past and hearing about those. But we will definitely look to do a bit more of that in the future, especially considering we could get feedback in the newsletter itself.
Rosalind?
Thanks, Julia. Yes, I just wanted to commend you on the excellent work. Absolutely. It's no surprise at all about the award and so forth. And just the user friendliness. I particularly like, you know, the frequently asked questions. You know, lots of us have experience, of course, of trying to do research in various contexts and various puzzles, and there's nobody to ask. So that's absolutely fantastic in terms of accessibility. And presumably you add to those frequently asked questions from time to time. So just well done. Thank you. Yeah.
Thanks. Just building on Tom's question, and the 10-year plan last week announced this new health data research initiative that, you know, quite extensively funded, that is anonymized data for ease of research. And, you know, not for today, but I just wonder if we explore legally, safely, ethically, etc., whether that's something we might want to be part of, because that gets our data to much wider use. And to Tom and other, you know, some of the points made earlier, that would help us get to some of the answers potentially around ethnic disparities and population health and all the rest of it. So I think it's something we should probably explore.
Thank you very much, Alex. So we are kind of in touch with the department, start making more contact with the department and other organization because of this increasing change in making the health data accessible and then linking together. And as Amanda mentioned, that we are looking into the potential way to share the data, trusted environment, or the federal analytic platform. So we have contacted a couple of places. And also, we are kind of looking at the Sadur's review. So we can kind of in line with the government strategic plan to make the health data available, but also we have very sensitive data. So we are kind of exploring the data to be in line with the department and our strategy. And then, we'll keep making more forward.
So thank you both very much. I do recall when I first took the chair at the HFEA and I was getting my feet under the table, one of the things I was thinking of, what do we do with our data? Because at that time we were still thinking about how we could make it more available, and we knew we wanted to make it available for research projects and so on, but we weren't quite sure how and so on. Really gratifying to see how far we've come and that it is available, because it's a really very rich seam of data. And I think, some of these projects will make a real difference in relation to both women's health and population health generally. And I think Alex's suggestion, or at least comment about trying to link it to where we could be with the 10-year plan or how we can assist, I think is excellent. So well done, and look forward to hearing more as you keep going. Thank you.
They stay? This? I think they need to leave. It's fine. It's a public. Amanda's involved in.
Yes.
Oh, right. Fine. Perfect. So the last item, or substantive item, is or the focus consultation on Tutor Fertility Clinic. So you will recall we actually discussed this whole area of Kafka Tutor Fertility Clinic, this great acronym, back in May, where we've noted that the data on our website that enabled patients to look at, people to consider how to choose a fertility clinic, hadn't been updated, I think, since 2018. And we agreed at that time that we should agree some metrics as an interim Kafka, and we consulted with the sector on what those metrics should be to enable just some interim updates to be on the website. We knew that wasn't the end of the story by any means, but was a step in the right direction. And now we're at the stage when we're looking to how to get from there to the full Kafka, and which will include another a focused consultation or to agree the metrics that we might want to use. So I'm going to hand over to Claire to really set the scene and explain to us what she needs from us today, and then we'll have some discussion and we will need to make some decisions. Yep.
Thanks, Julia. I'll speak only very briefly because hopefully the paper is clear. As you said, it follows a discussion and decision in the May Authority meeting, where a paper at that meeting looked at how treatment types have changed since Kafka had first been launched a few years ago. And it was agreed at that meeting to hold a focused consultation over this summer to get views from clinical staff and patients before we are publishing the full Kafka, hopefully later in 2025. The paper sets out the background and how we will go about doing that focused consultation. And in the second annex, the sorts of questions that we are going to be covering. We are in the final stages of drafting the wording, with the aim of it being as lay-friendly as possible while technically accurate. The authority agreed in May that following the publication of the full Kafka later this year, we will review the different information sources that we have on the HFEA website, and we've heard from Amanda and Kazuya about several of those resources, and consider whether all of those can be brought together in a more unified or different way. And I make that point because this paper outlines only this planned focused consultation on the headline metrics for the full Kafka publication later this year, not kind of wider discussions about what our website data might look like in the future. At the end of their paper, there is 3 questions for decision. The first one relates to carrying out a focused consultation. The second one seeks views on the 4 metrics set out in paragraph 4.3 and whether authority think these are the right metrics that we should be consulting on. And at paragraph 4.5 onwards, we look at whether, in line with the authority's decision, which was back in March 2025, relating to multiple births. So that decision was that as most clinics are now below the 10% target, at inspection, only clinics who were above the 10% target would be reported. It would only be reported in an inspection report where it was over the 10% target. So reported by exception rather than as per the norm. And the question for you is then a consequential decision of whether on the full CAFCA we display the multiple birth rate for every clinic as we have in the past, or we go in line with what we said in the inspection reports, and that we only show by exception where a clinic has a multiple birth rate of above 10%. So I will pause there and leave it to you.
So, questions, observations? We'd like to kick off. So I think the first, let's start with Francis here.
Yes, it's just a quick question. Paragraph 3, talk about 4 metrics: births per cycle, births per egg collection, births per embryo transfer, and births per embryo transferred. And I just wondered, is there a difference between the last 2? And if so, what is it? Or is there a 4th metric that's not on that list? It's paragraph 4.3.
Claire's very kindly offered that I answer this question. Yes, there's a big difference. Essentially, births per embryo transfer disregards how many embryos are transferred, whereas births per embryo transfer takes that into account. So centres that transfer more than one embryo will have a lower pregnancy rate when you look at the per embryo transferred pregnancy rate. So there is quite a big difference.
It does cause a bit of confusion, that, and I think the word procedure after embryo transfer might make it more clear. It's a non-running issue. A non-running confusing issue.
Noted. Tom?
Thanks. Just a couple of quick points from me. So overall, and I'm sure we'll get to this, but I agree with the overall approach. And I know you don't want too much detail because actually that's your job to go away and make sure it's appropriate and do the relevant checking. In terms of the respondents, when you describe the consultation overview, I would suggest, as well as on behalf of professional bodies, you maybe consider on behalf of the different clinics as well, because people might want to respond as staff or as an individual, but the organisations may also want to put in a response. And I think it's helpful to understand the difference between people giving their own views. That may be implicit, it just wasn't explicit in what was said. The other thing that I was going to say is I wholeheartedly support the approach of being focused. This is perhaps too detailed and too methodological, but I would suggest a kind of maybe a catch-all question at the end for any other comments that people want to say. I just feel it gives transparency for people to say things. I recognise there is a challenge in doing that it becomes harder then to analyse if there's large amounts of data in that sort of free text space, but a suggestion to consider. And finally, you did mention that this is not an assessment of all the data on the website and a full assessment and approach. It would just be useful to know if there is a consideration about when that might be looked at in the future, because I think it's not appropriate to do now. It's the right approach, but we do want to do it at some point. So just understanding when thinking about that would be helpful.
Thanks, Tom. Well, starting with the last question first, what we have set out as the authority agreed in the HFEA strategy, it will be during the lifetime of this strategy. So I can tell you it won't be this financial year, but I hope we can start that thinking next year with the acknowledgement that if we are requiring kind of quite structural changes to the website, that would take time to implement. On your comment about giving people the opportunity to add in further comments, absolutely. So there'll be as it says in the paper, the survey will be built in SurveyMonkey because that's what we're currently using. It's user friendly on phones or on laptops or tablets, etc. And there will absolutely be a box for people to add in any further comments at the end. And at the top of the survey, people will be able to kind of identify what capacity they're answering. So it may be as an individual, it may be on behalf of a clinic, it may be on behalf of a patient or professional organisation stakeholder group, and people could submit responses in kind of multiple different hats on, if you like. So in paragraph 3.6, we talked about how we can get it directly to those groups. So by directly to each person responsible in every licensed clinic. In multiple times in our monthly newsletter, Clinic Focus, which we know has a high open rate and goes to lots of clinic staff. Anyone can sign up to it on our website, and many clinic staff who are not PRs read it. Directly to both the patient and professional organisation groups that we work with, and also the HFEA Patient Engagement Forum, which has got just under 200 members.
Geeta. Thank you, Claire. Thank you for this very good paper as well. And yes, absolutely, we need this consultation done. A couple of things. Agree with Tim that I think making it clear per embryo transfer procedure would be good, because every time you have to explain it to the patient that it's per embryo transfer procedure. I don't know what my colleagues think. Personally, I am not keen on removing multiple birth rate from the headline figure, although we have achieved less than 10%. The natural multiple birth rate from natural conception is only about 1 or 2%. We're still above that anyway. So in some ways, I would still keep that, although we're doing extremely well and we should be proud of it. And the next points for me are stakeholders. When you say stakeholders and professional bodies, are we extending this to beyond just British Fertility Society or so? Because this should go to people outside of fertility group, like I've always been saying, obstetricians, neonatologists, because it really matters to them. The minute patient gets pregnant, they are taking care of them. What happens during pregnancy, what happens after the baby, they take care of them. So in some ways, I would encourage that we send it to more stakeholders, midwives, obstetricians, neonatologists. However, I mean, I don't know if we could think of more. RCOG should be involved. And when it comes to NHS commissioning, we still look at fresh transfers, and not everybody funds, not every ICB funds frozen cycles. Some may fund one, some may fund two. So the fact that the sector has moved predominantly from fresh to frozen doesn't mean it's a good thing. It's what has happened. But the NHS commissioning hasn't moved in that direction. It's not funding 6 frozen cycles or something. So it can affect NHS funded cycles. And finally, how do we advertise this? It should be far reaching, not just our own social media and website. Can we think of other ways, whether DHSC could be involved? I don't know, some other ways of making sure more people hear about it, understand this. And when it comes to clinics, it might be a good idea to try and maybe ask whether NHS or private clinic as well. Thank you.
Thanks, Geeta. I won't answer every single question. I think the general point, our professional stakeholder group does include wider organisations like the Royal College of Obstetricians and Gynaecologists, Royal College of Nursing, British Medical Association and others. I think that there will be a balance between quantity of responses and depth of responses and what we are able to analyse in the time available. So I think that's, I suppose, a question to just think about. We maybe don't have to answer today. Is, you know, if we got 15,000 responses, for example, I don't know when we would be able to come back to you for a decision. If we got, 3,000, I can confidently say, we'll come back to you in the autumn, having looked at those results. So I think we'll have to go away and have a think about how we balance the reach with what we have ability to analyse in the time available.
Catherine, yes, and Nadia.
Whenever I think about choose a fertility clinic, I'm struck by the need to
keep at the forefront of my mind, balancing clear, unambiguous, easily accessible information to patients with the responsibility to make sure that we are reflecting fairly the measures of clinic performance. Both must always be at the forefront of our minds, but there will be, or there may be, times where pursuit of one works to the detriment of another. And I think that for my money, at the point at which we seek out views on Kafka, we have to say that when push comes to shove, the absolute priority has to be the clarity of information to patients, which is not misleading and which enables them to take rational decisions about where they select their treatment. And to that end, whilst I'm in favour of saying to all those we consult that there should be an open-ended question, I would go further than just, is there anything you want to add? I would add two questions, or I would urge them to consider two questions. The first is any of the current metrics proposed, in your view, misleading to patients, and if so, why? And is there any additional or alternative metric that you would propose, and why? Because I think that focuses the mind of all respondents on the crux importance of clarity and unambiguous information to patients, because that's what we are fundamentally. Clinics, PRs, HFEA, patients, patient bodies, we should all be interested in as the most important thing.
Yes, you want to?
Quite a bit of that sort of already in the questions, so to speak, in the sense that we're going to ask people to sort of rank, and the surrounding text will allow us to get at that. I know exactly what you're saying, Catherine. So I think there are ways at getting at that. What we're trying to do as well with the bottom question, I think it's the point that Tom alluded to, in which I think it's absolutely right to give people an opportunity. The danger is the bottom thing becomes a sort of vehicle for an essay, which actually then makes the action, the analysis more difficult. But I get exactly, and we'll certainly try and sort of strike that kind of balance. The thing I think is worth putting on the public record at the moment is there is simply no perfect way to measure the performance of fertility clinics. And all of the metrics available across the world have different sets of pros and cons and different sorts of trade-offs. And equally, having 10 headline metrics isn't frankly helpful to your average patient and so on. So we'll be trying to sort of draw that out. A big theme of the consultation, if you like, will be trying to sort of make that point that, were there a standard way which had consensus amongst both, patients and clinics, we wouldn't even need to do this exercise. So, but we understand what you're saying, Catherine. And I think we've got already within the questions, by things like ranking and stuff, we've got ways of drawing out this sort of what do you think is best and why kind of element. But as we fine tune it, I'm sure we can find a way of striking that balance.
Anya.
Thank you. I really welcome this, and I think it will be really user friendly. It's just a plea, I think, for us to make sure that we're reaching out to groups that perhaps haven't had the same voice that other groups have. So I welcome, for example, the inclusion of the patient groups such as CANA, but it would be really good to be proactively reaching out to groups that perhaps haven't been as involved previously, such as groups from the global majority, maybe the Asian fertility support group, etc., so that it really is capturing a wide range of data. So it would just be useful to know how we're going to be reaching out to a wide range of people.
Thanks, Anya. That's a really good point, and it's something that we have developed our networks through, particularly the recent patient survey, But we do also rely to some extent on patient organisations, stakeholder groups like Fertility Network and others who run support groups for different people of different backgrounds and people of different family types going through fertility treatment. So it's something we can do some ourselves, but we also hope that it will be distributed by others as well.
I agree with Geeta about the multiple births. You got there first. When I read this, I mean, I thought probably a different decision as to the inspection reports as to whether it should be on Choose a Fertility Clinic, and I wasn't sure if the key line here was headline rate. So I think in the interests of transparency, we should have the multiple birth rate for every clinic within Choose a Fertility Clinic. I'm agnostic as to whether that should be part of the headline rate as made in the paper, and probably a discussion for another day. And, you know, going back to the last item, in the interests of transparency, we then have the rate for every clinic in the public domain, which means researchers can take that exact rate and do whatever they want with it, which might, you know, highlight other things. So I definitely think we should have that number there. But as I say, agnostic as to whether that should form part of the headline rate. And I wasn't sure if that was the nuance in the paper. And then if I could, just a not for today point, but again, going back to the 10-year plan and the announcement of My Choices, this new service where we will be able to have data to choose everything. Again, you know, once this consultation's over and when resource allows, I think we should explore whether Choose a Fertility Clinic, you know, is as, and they were very clear that My Choices will be helping you choose surgery wherever you want to have surgery in the independent sector or in the NHS. So again, you know, we should explore if we can whether this can form part of My Choices in due course, which I know wasn't today's agenda, but I wanted to make the point.
Yeah, I think so. In terms of the decision side of things, I fully support the full survey over the summer, and I've taken into account everything that's been said in terms of the wideness of who we're asking and the terminology around the 4 metrics. And I also agree. I think for completeness, multiple birth rate per clinic should be stated, but you know, there's a big difference between 2% and 9%, even though both those figures fall within the 10%.
Peter. Thank you. This is really good discussion. 2 things. One is, yes, Claire, thank you. That I think you do have some ways of reaching out to ethnic minority groups. We didn't get a huge response, but we did try for patient survey. Maybe if we could do that again, as well as single women and same-sex couples. There are groups, patient support groups, and also there are really very well established groups that if we could reach out to them as well. 4.4 is the one where I have a question. So do you intend to ask whether, again, everything should be combined? Because it's difficult for people to understand that. Why?
Sorry, I missed the question.
4.4.
Yeah.
Do you still plan to ask that question to respondents, whether everything should be combined?
I don't know if Peter wants to come in here. I mean, where we are in kind of our thinking is that I suppose 2 things. One is that as planned, try and make the survey brief and avoid identifiability, which changes kind of how we would analyse the data. We weren't necessarily going to collect demographic data from people. That changes quite a lot about how the survey is structured, how long it would take to build, and the analysis. So I think if that's an open question for members. If members think the demographic data is important to see kind of what family type respondents are from or ethnicity, then that would be good to get views on, and would have to take that away and kind of reanalyze how we're going to do it. But I'm very happy to have that discussion. On 4.4, I mean, I don't know if Peter or others want to come in here, but the way the survey is currently structured in draft is that these 4 rates, which we've talked about, people can rank which is, you know, the one that they favour, with explanations of kind of what that rate involves, whether it's cumulative, you know, etc. When it counts from, which I think from a patient perspective, you know, what does it, at what point during my kind of IVF does it count from? There then is discussions or explanations about how different data could be analysed or broken up. So including PGTA or excluding, including donor eggs or excluding, and whether people would like one rate that kind of includes all these things or not. And I suppose you're saying, is that still a useful question? I don't know, Peter, if you want to come in on why it should or shouldn't be there.
Yeah, very happy to. So I think there are two ways of thinking about this, Geezer. One of which is the rate, and then what are the treatments that are in any given rate? Yeah. So you could have births per embryo transferred, say, fresh only, births per embryo transferred, fresh and frozen, births per embryo transferred, fresh and frozen, but not including donation, and so on, right? And we rather than ask a whole series of very complicated questions about rate, what we're going to try and do is ask sort of, currently our thinking is there's 4 sort of rates, different ways of counting, and then a series of questions about what do you think should be included in your preferential rates. And we very strongly think, I think it's a very legitimate question, which is, you know, from the smallest sample, wouldn't it, would be fresh only, and the biggest sample would be everything. And we're going to ask a series of questions that allows people to make choices within those different components. So that's, we think, is the simplest way of doing this. And yes, we do plan. One of the questions we ask is, do you think that, you know, regardless of whatever rate you choose, actually it should combine all of those kind of treatment types? And we'll see what people say.
Well, Geeta, do you want to come back and then we'll go? We've got plenty of time. So
sure. Thank you. Thanks, Peter. And thank you, Claire. I mean, I don't believe that question is relevant now after the discussions we have had, because PGTA is actually an add-on. And we discussed that, and it's really PGTA to be included with just non-tested embryos as well as donor eggs. Once again, it's a different entity. So I think asking that question, people will understand that. Many people will understand how it is going to be different and why. That's my view.
The thinking to date is it's really important we get a range of things, and it may well be that lots of people come back and say no, that's fine, then we know. But I think that wide range is a relevant point at this stage. It's a properly open consultation in that sense.
Zainab.
Yes, thank you. Specifically on this point, I'm wondering if that question is going to be asked, and if we're looking for a very wide set of potential respondents, and to be able to offer these questions in as lay a language as possible, whether we might ask the question in terms of what is important for people to be able to differentiate between in the data, or what. So rather than sort of saying, should it amalgamate this, that, and the other, almost asking it the other way round, should the data allow users to be able to distinguish the success rates for a woman using her own eggs and a woman using donor eggs, for example? Or should the data allow people to be able to distinguish between untested embryos and tested embryos, or something like that, which would be much more lay friendly, and it would allow whoever's filling in the form, if they're not a professional in the field, to maybe offer a more informed perspective about what amalgamating or not amalgamating those things might mean.
Answers? So like Tim and Alex, I favour retaining the multiple birth rate, but just to comment about that, having spoken to many, many people facing infertility, their initial assumption is always that a multiple birth would be even better than one, and they may well regard clinics that have a high multiple birth rate as the ones that are most likely to be successful for them. So if we do include that data, I think there needs to be a very clear explanation that multiple births increase the risk of morbidity and mortality for both mother and baby, and that it's better to aim for a single embryo transfer, a single pregnancy, and use any additional embryos that you have in a separate cycle.
Just a quick response, Francis. Of course, there is a lot of that information already on there around the multiple birth rate, so we can look at it again. But principally, that's there. And you're right. We can look at the wording, Zainab. Of course, one of the things, of course, we're trying to get over in this as well. And remember, there is detailed in the full Kafka, there's detailed stats underneath this. The more you subdivide, the less reliable the numbers become. So one of the attractions in people say, oh, I want numbers that look very, very specifically like, you know, what I'm interested in. With a number of clinics, the activity levels they will do will mean the confidence intervals on those subdivided numbers become so wide, they don't really mean very much at all. So there is an issue about that. Greater, in statistical terms, greater specialization gives you much wider confidence intervals, such that actually, you know, the numbers don't mean a great deal. So that's a constant balance. And remember, as I say, for the full Kafka, we are talking both a limited number of so-called headline or front page metrics, which then you have detailed stats beneath. So, you know, there's a sort of, you can go down into more detailed data in the full.
Yeah, do you want to come back and then?
Yeah, just to come back really quickly on that. I think it depends how we define the word reliable in this context. And I absolutely take your point about, you know, statistical issues as you reduce numbers. But if we're thinking about the headline figures and who is going to be more likely just to look at the headline figures versus who's going to look at the headline figures and drill down into the more detailed figures, then I think it's also important for those figures to be reliable in that it is telling people what it is that they're looking for, which, you know, might be compromised if we lump everything together.
That's clearly part of what the consultation is trying to unearth. You can get into a situation with some metrics where certain small clinics, really quite modest adjustments in success rates in one given year will radically change their headline rate in a way that doesn't really reflect anything meaningful.
Steve.
Just in terms of this question that is giving people some difficulty around asking people whether the results should be amalgamated or kept separate. But it is a difficult question.
Sorry, speaking to your mic.
Oh, sorry. It's an important question, but it's a difficult question for people to get their heads around. I think it's worth reiterating, and I have had the advantage of having seen the draft. There is quite a lot of explanation around the pros and cons of one way versus the other, actually in the text that supports the questions. And that occurs throughout the whole survey. So I thought when I read it that it described quite nicely, as I say, the advantages and disadvantages of joining everything together to give one statistically more reliable number versus something which is more personalised to the patient that's filling the questionnaire out.
And I think it's worth saying that we have that the text has been looked at from a lay person's point of view. I think that's really important to note because, you know, these are quite technical, and so we've asked you know, other people to look at it. The authority have looked at it from a lay person's point of view to make sure it's sort of understandable. And I think that's important. Rosamond.
Thanks, Julia. Yes, so I support much of what has been said, and overall, I mean, I think this is all going to be caveat. I haven't seen the draft, have I? But I mean, caveated with the point that what is being asked is information that will be most useful for patients. That's the backdrop here, isn't it? Regarding the multiple birth point, yes, I was going to make the point that Tim made in backing onto Geeta and Alex. There's a difference between 2 and 9, etc. But Francis, you're absolutely right. Some people will think 9 is good. So if that is included, there needs to be the caveat about all of that. As regards this last point we've been discussing, is there any possibility of having both figures, albeit that one would not be a... I appreciate you're moving away from headlines then, or at least you're adding additional information to headlines. So there is the availability of this more detailed information, the non-composite information in some other context, for example, because we don't know what is important to some patients. But I appreciate in terms of headlines, that's not a headline point, is it? So it's just about the availability of that other information somewhere. which might be helpful. But yeah, I appreciate that's a different point in a way. Yeah, thank you.
Just a reminder that what we're talking about, I think, is the kind of the screenshot that we put on Annex A, that kind of front page. The detailed statistics that you can click through will remain the detailed statistics, and people can kind of break them down, different age groups, etc. And secondly, if the decision is that the multiple birth stays on that front page, then if you look at any clinic now on our, that won't, unless the text is no longer accurate, it will look as it does now. So kind of no change there is the answer. So at the moment it talks about multiple births, the multiple birth rate, the risk of multiple births, etc. So if the authority decide then that should stay, then that is kind of continuation of what we currently have.
So just on that, is there anybody we haven't heard from on the multiple birth rate? Because, okay, so I think maybe then I can just ask, I know Alison had to step out, but she'll come back in a second. I guess we'll just show of hands just to start with, the easiest way. Who's in favour of retaining the multiple birth rate as a headline metric? Yeah, it's pretty unanimous. Is anybody actually against it? Or
I think I'm abstaining as an impending grandmother of twins. Congratulations. Not naturally conceived. But,
okay.
So
yeah.
Twins are not a disaster.
We'll
didn't quite know how to answer that, really. No, great. All right. So look, I think Peter, you got your answer on,
so in fact, we will consult on the multiple birth rate.
Yes.
So it's a choice.
Yeah, I think let's consult on it, because
we're just assuming it's on regardless.
Should we just, yeah.
I think in the introductory text, we will say that it will the front page headline statistics will continue to show a clinic's multiple birth rate and where it is above or below the target.
I think that's fine. Anybody else? Yes, Christine.
Yes, just a sort of trivial question, Claire. How many responses do you think you might get, and how will you ensure that you've actually got a sense of the full range of opinion from all the interested parties?
So I think this is the question back to authorities. So when, for example, we do the patient survey, we work incredibly hard over many, many, many months to ensure we have a representative sample of patients. So we look at the register data and look at the spread across the UK, NHS private, ethnicities, age groups and family types. And that is a lot of work to make sure we have the representative sample, which we were successful with. And I should preface anything I'm going to say, and a reminder is in the survey, CAFCA is not a predictive tool for any individual patient. So it can only give people a sense of how one clinic looks compared to another in terms of what measures they have. And also we know from both our patient survey and other feedback that in fact location and price remain the two top reasons why people are choosing clinics. But we know that the Choose a Fertility Clinic part of our website is also the most used part of our website. So I suppose a question back for authority is, not sure how to frame it, where the spread of responses that you're most interested in hearing. So are you kind of more interested in what patients think than clinic staff, or equally? So, you know, if we asked respondents to say whether they work in a clinic or they're a patient and only 3 clinic staff respond, you know, is that important to you? But do you want us to collect demographic data about patients? And if, for example, when the patient survey, you know, say we had it open for 2 weeks, we would review and say, you know, actually we have had no single patients respond, and we did a whole kind of, you know, extra work to get that demographic group. So, you know, we would then need to ensure we're doing that for this. So I think that's an open question back to members about the demographic split, whether we collect that information and how important it is to reflect to you that, for example, people who live in the northeast like this measure, whereas, you know, those who are in Wales prefer that one, and those who are single patients.
Thanks. A few points, and I'd just like to say it's a really interesting conversation. And I am assured that we have plans in the future to look in more detail, because actually this is a staged approach about improving what we're providing. First off, I would just like to say that it is really helpful to hear Stephen, who's sort of looked in detail about this, that this is a description of the different options. And I think that the conversation that we have had highlights that actually what we are interested in is people's comments on the pros and cons of this. And so from my understanding of what's been said, this is partly designed to assess that. And actually that's the insight that we probably need to make the decisions on how to actually what we want at the front. So it's really helpful to hear that perspective, and that certainly assures me. With regard to your question on demographics and the level of detail on that, I do appreciate the point, but I also appreciate that there's an issue about simplicity and enabling people to respond, and the more information that you ask, the less that you want to do. I sort of go back to my original point, where I think it's really important to know if people are responding on behalf of organisations versus responding on behalf of themselves. And I think clinical staff versus the public is an important distinction. The final point that I wanted to make in terms of how we collate and consider this data is, and I think this is implicit, but I don't think it's been said, is my personal view is that this is to inform the decision on what we do. It's not going to determine the decision, and therefore we will take this, we will take the information, the points about the sort of spread, and do we actually have different sets of information, and how representative we feel that reflects it. We may make a decision, we need more information on that space because of it, but it's not the determining factor. And so it's an aid for us to make the decision on what we do next. And I just think that's a really important part in thinking about how we take it forward. So again, overall, I'm broadly comfortable with the general approach, with like a few, sort of making sure that we meet Catherine's needs. And I do think it's useful to just capture, is there anything else that someone would have as an alternative, just as part of this, but overall that's to inform our decision making.
Really pleased Tom said that, because I think this is really important. And again, for the public record, this isn't a plebiscite. This is a consultation to inform decisions made by a statutory expert body. It's entirely likely that the information you'll get back will be somewhat contradictory. I say that from long experience. And equally, there's a tendency in these things to kind of think, oh, if only we asked this, or if only we had some other way of subdividing the data, this would provide us with the answer. But the likelihood is, whether or not it's regional information or something or other, it'll all sort of sit in some sort of contradiction each other. We may be very lucky, and there may be a very, very clear steer that 90% of both patients and clinic staff agree about X, in which case it tends to make the decision simpler, albeit it's still not a plebiscite, but it's much more likely to be split with all sorts of choices. So it is, what we're trying to design here is a fair, open-minded, but yet simple way of getting a sense of where whole groups of people feel about a number of things that will allow you, in the light of all that opinion, to make a decision. But it is to inform the decision, not to take the decision for you, because otherwise we might as well not even have the authority meeting. We'll just tally up the numbers and say, there's our answer. And it's a really obvious point, but it is to inform that. So, and again, also there's some evidence to suggest that surveys that have very finely graded demographic detail before they start actually put people off from responding, because there's so much it takes them so long to get to the point where they can actually answer the substantive questions they wanted to ask. They just give up. So we will need to strike some, my words are just, we will need to find some sort of balance which achieves the sorts of things that Tom and many others you have, because there is not only is there not a perfect rate to measure a fertility clinic, there's not a perfect way to conduct one of these exercises only.
Peter.
Thank you. Peter, I completely agree with you. This is going to be quite difficult, isn't it, to try and achieve what we want. But what we want to achieve, I mean, basically the whole purpose is to try to help patients or inform patients about which clinics are likely to give them the best chance of success, and potentially with multiple birth and other, safety as well. So patients are important. So I was just thinking, I know it's going to be very, very difficult. We're going to try, we'll have to try and get as many responses from patients as possible, as well, and also stakeholders like professional organizations who actually really understand what, although this is not really representative of success, as to how to balance success with risk. But is there anything like you'll say, okay, if you only got 10 patients to respond and 1,000 people from clinic staff, is that relevant? Is that meaningful? And so we'll need to put our efforts to try and get as many responses as possible from patients from across all the regions and also communities and stakeholders to make this meaningful.
I don't think I have much more to add to what I said previously, that I think it's a balance between authority getting the analysis of this in the autumn and making a decision about the publication of the full CAFCA, and balancing with other, this is absolutely a central part of our work. There are other things that we also need to manage over the next few weeks. So I'm not sure how to answer that, kind of about the balance between quantity or numbers of patients versus number of clinic staff.
Yeah. Can I?
Yeah, I think I'll leave that there.
Would it be helpful maybe if I just draw this together, because it's been a very, very helpful and a very important discussion. I think, and without putting words into the authority's mouth, I think we all agree that this is really important, and it's an excellent time. It's excellent that we put the interim CAFCA up. We knew it was just a roadblock or a measure on the journey, if you like, and then we're going to get to the full CAFCA, and I think we probably also agree, but put your hands up if I'm wrong, that in an ideal world we would want the consultation done in the autumn so that we could publish the full CAFCA, hopefully, fingers crossed, but by the end of the year, because at the moment, the information is incomplete, and that's worse. We all agree that's worse for patients than complete information, or not as helpful for patients as complete information. And I take Catherine's point absolutely, that I think everybody, and I think clinics would agree that as well, that what is most important in all this is to make sure that patients feel they can trust the information and feel comfortable with it and feel it's useful for them and want to go and use it, continue, because they do already, continue to use the CAFCA button, if you like, on the website. So in order to do that, I think what we're hearing from Claire and Peter is that we can do this, and the timetable will work if we have a focused consultation. And I think the trick is in the word focused. I think it needs to have the right balance of clinics, stakeholders, patients in the right way, whether that's, as Tom said, groups rather than individuals. I think it would be helpful to have a demographic split, but from what I'm hearing, it's not particularly helpful to analyze this from a demographic point of view. I think we just need to be canny about how we, to whom we send this survey. I would suggest that if this is the view of the authority, we leave it now in the hands of Peter and Claire and so on to say, to decide who to send it to on the basis that is, we need a balance. We obviously need to get to a point where patients are comfortable and so on. In a way, I think we have to trust the exec to do that for us and say, you find the right people, because I have confidence that they will do that. And therefore, looking at the questions for the decision, I think if we're happy, that's the first thing. Are we happy on that basis? Because if we are, I think we should agree that they should be aware of this conversation. They should look at a good balance, but with the ultimate aim, if possible, to get the consultation out in autumn, so that we can then, in a sensible way, to a sensible number of respondents, to allow us then to publish full Kafka towards the end of the year, if that's possible. I realise, there are a lot of caveats in that, but that sort of feels the general idea. Claire.
Just to clarify, when you say get the consultation out in autumn, do you mean get the consultation out to report to authority in autumn?
Yes, sorry, August, middle of August, whatever date it is, in order for it to come back to us in the autumn. Sorry, I was unclear. So firstly, can I have sort of an indication of a decision on that? Is everybody happy with that? Yeah, is that fine? Okay. Then the next question is that, and I'll come to multiple births in a minute, the views we should seek are on the 4 metrics in 4.3, with some a little bit of an additional, maybe embryo transfer procedure as the wording and so on. But is everybody comfortable that, if we do it right, these are actually the metrics? Yeah, okay, that's good. And lots of nods for those online to say that I think the authority is agreeing, and that from what I'm hearing, we keep the multiple birth metric in, so we in fact don't need to consult on it because it's already there. So it's sort of, yeah. So for the benefit of anybody online or everybody online, the authority is been asked for those 3 points, so the focus consultation going out, the 4 metrics, and the multiple birth metric stays where it is, and I think that's pretty, in fact it is unanimous. Yep. Now, Claire, Peter, you're happy with that? Yep. Okay, all right. Well, look, thanks everybody. It's a really good discussion. And we'll be discussing this again. I imagine this is in the autumn. We're on a journey. We're not at the destination. So there's time. Good. Now AOB. Anybody got any? I'm just looking around the table. I've only got one thing, which is the next meeting is the 25th of September. And don't freak out because we've made a typo. It is, in fact, a Thursday, which I know is very unusual and by exception. In fact, I think in the however many years I've been here, we've never had a meeting on a Thursday, but for various reasons we have to. So I think it's in everyone's diary. It is good. We like to mix it up. And just remains for me to say, have a lovely summer, because and see everybody in September.